Welcome. ఇది కొట్టరు కదా అంతేనా ఇది సో వెల్కమ్ టు ద ఇది welcome to the refreshing of urea cycle, and I am very happy I have gone through your exam answer sheets. Most of you wrote the urea cycle very nicely. I don't think that I need any refreshing for you in this matter, but anyhow I'll mostly concentrate on the clinical applications of the urea cycle with which you are not conversant, and this will definitely introduce you to the clinical medicine, especially the pediatrics, because this is a real emergency in the beginning of the life for the pediatric cases, isn't it? So you know all this, the substrates for urea cycle, alpha amino acid converting into alpha keto acid by the help of alpha ketoglutarate converting into glutamate, and the NAD plus H2O will be giving rise to NADH plus ammonia. So here in the other side, the acyl acetate getting converted into aspartate is another one. So these are the two steps. These are the two substrates for urea cycle. I need not stress all these things because it will be a umpty number of repetitions for you. So this is the mitochondrial matrix and cytosolic compartment of urea cycle, and all of you have written very nicely this, so I need not go through this. So aspartate and carbonyl phosphate each deliver an amino group to the cycle, and carbonyl phosphate production and condensation occurs in the mitochondrial matrix. So this you have to remember for Viva. Carbonyl phosphate production and condensation occurs in the mitochondrial matrix. So hexameric glutamate dehydrogenase is controlled allosterically. High energy levels inhibit ATP and GTP. When they are there, it will inhibit it, and low energy levels activate ADP and GDP. If they are present, they will activate. So NADP plus can replace NAD plus. So NH4 ion, which is toxic to humans, is produced in the mitochondria and used to make carbonyl phosphate. So this is the area where you call whether it is God or the Mother Nature that is helping us to save the human race from getting annihilated. So NH4 ion, which is toxic to humans, is produced in the mitochondria and used to make carbonyl phosphate. Mitochondria is salvaging the human race, maternal mitochondria, remember. So carbonyl phosphate synthetase is in the mitochondrial matrix. If mitochondrial acquired diseases are there, the problems will be more, about which we are going to read. So NH4 is a source of NH3. So the hydrolysis of 2-ATP makes this reaction essentially irreversible. So this is what we have to remember for Viva. The hydrolysis of 2-ATPs make this reaction essentially irreversible. You know all the urea cycle and the disorders, but the explanation like this is most essential for you to convert you into an active clinician. So carbonyl phosphate synthetase is in the mitochondrial matrix. NH4 ion is the source for NH3 ammonia. The hydrolysis of 2-ATP make this reaction essentially irreversible. N-acetyl glutamate is an allosteric activator. N-acetyl glutamate is available in the market as Nephrosafe. So you know this is the urea cycle with all structures: arginosuccinate synthase, arginosuccinase, arginase, ornithine transcarbamylase. So here connection to Krebs cycle is most important. Most of you have written this, but all of you have not written this in your answer scripts. So you should be careful enough to remember this, to incorporate this into your answers. Then the examiner, the valuer of your paper will be very happy at your versatile knowledge. So whenever I have seen this with some of your classmates' answers, I was very happy. Fumarate is oxidized to oxaloacetate by Krebs cycle enzymes, producing NADH. Oxaloacetate accepts an amino group instead of being condensed with acetyl CoA. This is the most important thing you have to remember in Viva. Fumarate is oxidized to oxaloacetate by Krebs cycle enzymes producing NADH. Oxaloacetate accepts an amino group instead of being condensed with acetyl CoA. So for high energy, the reactions and energetics is most important. All of you have written very nicely, so I need not tell this. For high energy, phosphate bond equivalents are used for the reactions. 2 NADH are produced. So the net reaction is normal blood ammonium ion is 10 to 40 micromoles. Deficiencies of carbamyl phosphate synthesis or of any enzyme in the urea cycle causes high ammonia group, affects the central nervous system and can lead to irreversible brain damage. This is for which we have to fear, and that's why active intervention is most essential as early as possible in the child as soon as he wants, and that's why I am trying to give all this knowledge to you at this stage. So treatment strategies depend on which enzyme is deficient. So this is arginosuccinase deficiency. High dietary oxygen provides the path for carbamyl phosphate and aspartate. Nitrogens to produce arginosuccinate, which is excreted. Hippurate and phenylacetyl glutamine is excreted. Amino groups to glycine and glutamine by transamination. So you know pretty well, how many number of times I have told you this, ketogenic and glucogenic amino acids. After removal of amino group, the keto acids are used to make Krebs cycle intermediates. That's pyruvate, acetyl CoA, and acetyl CoA. Urea is a major source of nitrogen for oral bacteria. This is out of way for you, but anyhow, if you know this, you'll be happy to talk with your the dental colleagues. Most of your classmates may be in the dentistry, and dental pathology is the major subject. Urea is a major source of nitrogen for oral bacteria. It diffuses through most membranes, and it is in saliva. Bacterial urease produces ammonia. So glutamate dehydrogenase incorporates ammonium ion into alpha keto acids to obtain amino acids for bacterial growth. So when NH4 ion is limiting, it doesn't bind glutamate dehydrogenase, and the lower two reactions are used then. Streptococcus salivarius urease activity affects oral microbial ecology. You have to remember for your classmates, colleagues. It produces ammonia, which in addition to promoting growth, neutralizes the acids produced by other bacteria in the oral cavity. So the Streptococcus salivarius urease gene was introduced into Streptococcus mutans, GS5. It was expressed and during glucose metabolism reduces pH, decrease in duration. So nitrogen fixation. Now we'll go to the proper neonates with hyperammonemia. So what is urea cycle? The urea cycle is the metabolic pathway that transforms nitrogen to urea for excretion from the body. So normal urea cycle, you know it pretty well. So symptoms of newborns with urea cycle defects. Here we are introduced to newborns with urea cycle defects. So normal appearance will be there at birth. Irritability progressing to somnolence. They will be just అలాగా మత్తుగా నిద్రపోతూ ఉంటారు అంటే. Lethargy, activity మెల్లిగా క్లియర్ అయిపోతూ ఉంటుంది, అసలు యాక్టివిటీ ఉండదు. Then they will enter into coma. So remember, normal, everybody will be normal at the birth, but irritability progressing to somnolence, lethargy, and then coma. These are the three things you have to remember. Increase the diagnosis of newborns with urea cycle defects. Loss of thermoregulation. They will be having hypothermia. చాలా చల్లగా ఉంటుంది వాళ్ళ బాడీ అంతా. They will be feeding disruption. They will be increasing catabolism. Neurologic posturing. వాళ్ళు సెరెబ్రల్ ఎడిమా ఉండడం వలన వాళ్ళు పడుకునేటప్పుడు వాళ్ళు అస్యూమ్ చేసే పాస్చర్ చాలా peculiarగా ఉంటుంది. If you have seen one with cerebral edema, వాళ్ళు పడుకోవడమే చాలా క్లమ్జీగా పడుకుంటారు అనమాట. Then diseases, fits వచ్చేస్తే పాపం, hyperventilation, and then sometimes hypoventilation following hyperventilation. So dramatic and rapid increase in nitrogen load from trauma. వాళ్ళకి ఏదైనా దెబ్బ తగిలి హాస్పిటల్లో జాయిన్ అయితే dramatic rapid increase in nitrogen load during trauma, rapid weight loss and autocatabolism, increase in protein turnover from steroids, tend to avoid protein in their diet. Kinarvan, protein diet pedite naaku ishtam ledantaru. You will see most of the people in girls like this. They will tend to avoid protein in their diet. Often they have the history of behavioral or psychiatric illness. చాలా డిస్టర్బింగ్గా ఉంటారు అనమాట. ర్యాపిడ్ డిటెరరేషన్ ఆఫ్ న్యూరలాజిక్ స్టేటస్, సివియర్ ఎన్కెఫలోపతి, ఇన్కన్సిస్టెంట్ విత్ మెడికల్ మేనేజ్మెంట్. సో కామన్ క్లినికల్ ఫీచర్స్ ఫర్ లేట్ ఆన్సెట్ యూరియా సైకిల్ డిసార్డర్స్ ఈస్ ఇన్ అడల్ట్హుడ్. ఎవిడెన్స్ ఫర్ సెరిబ్రల్ ఎడిమా బై క్లినికల్ ఎగ్జామినేషన్ ఆర్ రేడియోగ్రాఫ్. రేడియోగ్రాఫ్లో సెరిబ్రల్ ఎడిమా క్లియర్గా కనపడుతుంది అనమాట. సో రేడియాలజిస్ట్ విల్ రిపోర్ట్ ఇట్ యాజ్ radiological evidence of cerebral edema. So seizures in some cases will be seen, decrease in oral intake leading up to decompensation. So these are the things you have to remember. You have to mug it up. You have to register it in your brain. So gene name is carbamyl phosphate synthetase 1. Gene symbol is CPS1. Location is short arm 2 chromosome, short arm 25. Protein name is carbamyl phosphate synthetase ammonia. Second one is ornithine transcarbamylase OTC XP21-1 ornithine carbamyl transferase. Arginosuccinate synthase is another one, ASS. That's the gene symbol. Don't pronounce it as S. That's why I read it as ASS. 9q34. Arginosuccinate synthase is the protein. Arginosuccinate lyase is the gene name, which is symbolized as ASL. 7 centroid Q11-2. Arginosuccinate lyase. Arginase, this is most important, gene symbol ARG1, 6q23, arginase 1. N-acetyl glutamate synthase, NAGS, 7q21-3, N-acetyl glutamate synthetase. Ornithine transporter mitochondrial 1. Ornithine ORNT1, 13q14, ornithine transporter mitochondrial 1. Citrulline, that is citrulline. We commonly call it as citrin. Citrin 7q21-3, proposed hepatic mitochondrial aspartate transporter. So now, this is the most important one. You have to remember and mark it up as long as you are living as a doctor on the face of this earth. Deficiencies of CPS1, ASS, ASL, ARG, NAGS, ORNT1 and citrin are inherited in as autosomal recessive manner, whereas OTC deficiency only is inherited in X-linked manner. Remember this, I am repeating. Deficiencies of CPS1, ASS, ASL, ARG, NAGS, ORNT1 and citrin are inherited in autosomal recessive manner. OTC deficiency is inherited in X-linked manner. So you know pretty well, N-acetyl glutamate synthetase deficiency, NAGS. You see this in mitochondrial compartment. N-acetyl glutamate contributes to the development of CPS1. So N-acetyl glutamate synthetase deficiency, NAGS, affects the body's ability to make N-acetyl glutamate, which is required cofactor for the function of carbamyl phosphate synthetase 1. Without NAG, that is N-acetyl glutamate, CPS1 cannot convert ammonia into carbamyl phosphate. So this is the strategic step. Along with OTC deficiency and CPS1, deficiency of N-acetyl glutamate is the most severe of the urea cycle disorders. ఆదిలోనే హంసపాదం అంటారు. సో బిగినింగ్లోనే దెబ్బతింటుంది అనమాట బేబీ తాలూకా సిస్టమ్. Patients with complete NAGS deficiency rapidly develop hyperammonemia in the newborn period itself. Puttagane. So this is the area where you should be very careful, even though you are a very good gynecologist and a very good obstetrician, unless and otherwise you diagnose this problem, you are not going to benefit the parents. చేతికి ఇచ్చిన తర్వాత బేబీ చచ్చిపోతే పేరెంట్స్ బాధలు ఎలా అని వర్ణిస్తాం. సో ఇది గమనించడానికి మీకు ఈ నాలెడ్జ్ ఉండాలి. Along with OTC deficiency and CPS1 deficiency, deficiency of anisetyl glutamate is the most severe of the urea cycle disorders. Patients with complete NAGS deficiency rapidly develop hyperammonemia in the newborn period. So you remember this in the mitochondrial compartment, the anisetyl glutamate, and here carbonyl phosphate. So carbonyl phosphatase synthetase 1 deficiency, CPS1 deficiency. So this enzyme takes ammonia and through the use of bicarbonate and ATP produces carbonyl phosphate. This is the first step. All of you written in your exam nicely. So this enzyme requires the presence of its cofactor, N-acetyl glutamate, along with OTC deficiency and NAGS. Deficiency of CPS1 is the most severe of the urea cycle disorders. In the beginning itself, patients with complete CPS1 deficiency rapidly develop hyperammonemia in the newborn period. Remember this. This is for the present most important for your viva. Patients with complete CPS1 deficiency rapidly develop hyperammonemia in the newborn period. Patients who are successfully rescued from crisis are chronically at risk for repeated bouts of hyperammonemia, and patients with partial CPS1 deficiency can present at almost any time of life with the stressful triggering events. So stress panikiradu valaki. Stress unnadi ante hyperammonemia ki elipotharu. So remember this. Repeatedly I am showing that OTC combines carbonyl phosphate with ornithine to make citrulline, which is subsequently processed into urea. So at every step in this urea cycle, all the 5 steps are more important. All the 5 enzymes are most important. That's why I'm trying to drive the point into your brain at this stage of your life. So most of you, when you understand this urea cycle, you will be a successful pediatricians and successful neonatologists at a later stage of your life. Ornithine transcarbamylase, OTC deficiency. OTC combines carbonyl phosphate with ornithine to make citrulline, which is subsequently processed into urea. Every step you have to remember clearly. Along with CPS1 and NAGS deficiency, OTC deficiency is the most severe of the urea cycle disorders. ఒకటి రెండు ఇప్పుడు మూడోది కూడా తోడైందనమాట. Along with CPS1 and NAGS deficiency, OTC deficiency is the most severe of the urea cycle disorders. ఏది కాదు, అన్ని most severe. Patients with complete OTC deficiency rapidly develop hyperammonemia in the newborn period. Patients who are successfully rescued from crisis are chronically at risk for repeated bouts of hyperammonemia. OTC is located on the X chromosome. అందుకే దీని గురించి మొదట్లోనే చెప్పాను. OTC is located on the X chromosome, which results in the majority of severe patients being male. Male Y chromosome అని గుర్తుపెట్టుకుంటారే, X chromosome on both the compartments, on both the genders will be manifesting this. Remember this. OTC is located on the X chromosome, which results in the majority of severe patients being male. Ornithine transcarbamylase deficiency, OTC deficiency. Females can also be affected, but tend to present outside the neonatal period. ఆడపిల్లలు పుట్టినప్పుడు బాగానే ఉంటారు, బట్ పెద్దవాళ్ళు అయిన తర్వాత ప్రాబ్లమ్స్ బాగా ప్రజెంట్ అవుతాయి అన్నమాట. So females can also be affected, but tend to present outside the neonatal period. They are safe in the neonatal period, but once they grow up into చక్కగా ఆడపిల్లలు పెరిగి అందంగా ఇంట్లో తిరుగుతునేటప్పుడు పడిపోతారు. Arginosuccinate synthetase deficiency, ASSD, that is known as citrullinemia 1. So arganosuccinate synthetase deficiency, ASSD, citrullinemia 1. This enzyme combines citrulline with aspartate to form arganosuccinate. Patients with complete ASSD present with severe hyperammonemia in the newborn period. The use of arginine in these patients allows some ammonia to be incorporated into urea cycle, which makes treatment somewhat easier than other defects in the cycle. అందుకే మనం 5 months అప్పుడు టిఫా స్కాన్ తీసుకున్నప్పుడు ఏదైనా కిడ్నీకి సంబంధించిన ప్రాబ్లమ్స్ కనబడినట్టయితే వీ హ్యావ్ టు ఇన్కార్పొరేట్ ఆర్జినిన్ ఇంటు ద డైట్. ఆర్జినిన్ పౌడర్ ప్యాకెట్లు దొరుకుతాయి అన్నమాట. బట్ అఫ్ కోర్స్ కాస్ట్లీ, 16 rupees to 35 rupees ఉంటాయి. ఎండోవాస్ అనే పేరుతోటి ఈ ఆర్జినిన్ బాగా దొరుకుతుంది. అది బీపీ అది ఎక్కువ అయిపోకుండా కూడా కాపాడుతుంది అనమాట, అడిషనల్ బెనిఫిట్. అందుకోసం ఎండోవాస్ ఇస్ ద బెస్ట్ వన్ that will be prescribed by most of the obstetricians, including me. So the use of arginine in these patients allows some ammonia to be incorporated into the urea cycle, which makes treatment somewhat easier than other defects in the cycle. In margam undi kabatti easier anamata. Citrulline levels in these patients can be hundreds of times of the normal values. Sudam it gurinchi. So citrulline deficiency, citrullinemia type 2. So citrulline, another citrin anta anamata. Citrin deficiency is otherwise known as citrullinemia 2. Autosomal disorder that results in defective transport of aspartate in the liver, resulting in limitation of activity for the enzyme arganosuccinic acid synthase, which combines aspartate and citrulline to make arganosuccinic acid. This defect can present with classic newborn hyperammonemia, intrahepatic cholestasis, jaundice, and fatty liver, but is more likely to present with insidious neurologic findings, hyperammonemia, hypercitrullinemia, and hyperlipidemia in adulthood. Mood HHH antaru deenni tarvata telusukundam. Majority of patients reported are Japanese or Asian, sharing a common mutation. మన వాళ్ళందరూ దీనిలోకి వస్తారు. Patients tend to avoid carbohydrates rather than proteins. ఎక్కువ కార్బోహైడ్రేట్ డైట్స్ పెడుతున్నప్పుడు ఇష్టపడరు, నాకు వద్దండి అనేస్తుంటారు. ఎందుకంటే వాళ్ళకి మెటబాలిక్ ప్రాబ్లమ్స్ వచ్చేస్తాయి అన్నమాట. ప్రోటీన్స్ మళ్ళీ ఇష్టపడతారు, తింటారు. సో arganosuccinate lyase deficiency is otherwise known as arganosuccinic aciduria. This is the one I have done for my thesis. Arganosuccinate lyase deficiency, that is arganosuccinic aciduria. Deficiency of this enzyme prevents the conversion of arganosuccinate to the amino acid arginine, which affects the urea cycle and other biochemical pathways. This enzyme defect is past the point in the metabolic pathway at which all the waste nitrogen has been incorporated into urea cycle as arganosuccinate. Severe defects often present with rapid onset hyperammonemia in the newborn period. Arganosuccinate lyase deficiency, that is arganosuccinate aciduria, is marked by chronic hepatic enlargement and elevation of transaminases. Biopsy of the liver shows enlarged hepatocytes, which may over time progress to fibrosis. That is the picture, and the etiology is not clear even till today. And some of you should get a Nobel Prize for finding the etiology for this histopathological appearance. So it can also develop trichorexis nodosa. This is most important finding. వాళ్ళ బుర్ర మీద వెంట్రుకలన్నీ ఇలా 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 చుట్టుకు ఉంటాయి అన్నమాట, జుత్తులు మూటలు కట్టేసి ఉంటాయి అన్నమాట. వీళ్ళు పుట్టగానే ఇలాంటివి కానీ డెవలప్ అయితే మనకి గ్రామాల్లో చెప్తుంటారు, ఏదో మొక్కుకున్నారమ్మా మీరు, ఆ మొక్కుబడి తీర్చుకోకపోవడం వల్ల తలంతా జుత్తులు కట్టేసి ఇలా మూటలు కట్టేసినట్టు ఉంటున్నాయమ్మా, మీరు తలంచుకొని గుర్తు చేసుకొని ఆ మొక్కుబడి తీర్చుకున్నట్టయితే ఇవన్నీ పోతాయమ్మా అంటారు. సో దిస్ ఇస్ నోన్ యాజ్ ట్రైకోరెక్సిస్ నోడోసా. ఎవరైనా చంటి పిల్లలకి కట్టలు కట్టేసిన జుట్టు కనబడితే యూ హ్యావ్ టు రిమెంబర్ దిస్ arganosuccinic aciduria. So they will develop, the children will develop trichorexis nodosa, a node-like appearance of fragile hair ఇలా పీకితే ఊడిపోతూ ఉంటాయి పాపం, విరిగిపోతూ ఉంటాయి హెయిర్ అంతా. దే యూజువల్లీ రెస్పాండ్ టు ఆర్జినిన్ సప్లిమెంటేషన్. సో ఆర్జినిన్ సప్లిమెంటేషన్ ఇచ్చినట్టయితే వాళ్ళకి ఆర్జినిన్ రిచ్ ఫుడ్స్. Argin rich food. What is the argin rich food? Prawns. So if you try to feed them, develop them into the habit of taking feeds, so marine fish తీసుకునే అలవాటు చేసినట్టయితే వాళ్ళకి ఈ ట్రైపరెక్సిస్ నోడోసా క్రమంగా క్లియర్ అయిపోతుంది. సో ఆర్జినేస్ డెఫిషియన్సీ is otherwise known as hyperarginemia. So arginase deficiency presents with progressive spasticity. గట్టిగా చేతులు కాళ్ళు బిగుసిపోతూ ఉంటాయి. మోర్ ఇన్ ద లోవర్ లిమ్స్. కాళ్ళు బాగా ఇలా కన్నేసినట్టు ఉంటాయి అన్నమాట. కాళ్ళు మడుచుకోలేరు, నడవలేరు, సరిగ్గా నిల్చోలేరు, పడిపోతూ ఉంటారు. సీజర్స్, ఫిట్స్ వచ్చేస్తూ ఉంటాయి. అండ్ గ్రాడ్యువల్ లాస్ ఆఫ్ ఇంటలెక్చువల్ అటైన్మెంట్స్. ఇంటలెక్చువల్ అటైన్మెంట్స్ మెల్లిగా పోతూ ఉంటాయి. అండ్ దే విల్ ఎండ్ అప్ ఇన్ ఫెయిల్యూర్ టు థ్రైవ్. అందరి పిల్లల్లాగా ఆనందంగా బ్రతకలేరు. అదర్ సిమ్టమ్స్ దట్ may present early in the life include ఎపిసోడ్స్ ఆఫ్ ఇరిటబిలిటీ, అనోరెక్సియా, ఏమీ తినరు, అండ్ ఓమిటింగ్, మాట్లాడితే ఓమిటింగ్, కక్కేసుకుంటూ ఉంటారు. సో ఆర్నిథిన్ ట్రాన్స్లోకేస్ డెఫిషియన్సీ, HHH syndrome. I have told you before. So ornithine translocase deficiency, HHH syndrome. The HHH syndrome means hyperornithinemia, hyperammonemia, homocitrullinemia, citrullinuria. So అవి 3 Hలు. సో hyperornithinemia, hyperammonemia, homocitrullinuria. Defect in ornithine translocase results in diminished ornithine transport into the mitochondria with the ornithine accumulation in the cytoplasm and reduced intramitochondrial ornithine, causing impaired ureagenesis and aortic aciduria. Homocitrulline is thought to originate from transcarbamylation of lysine. That's the origin for it. Most of the times this will not be asked for you even in the viva, and this is mostly specific for the postgraduates only. Ornithine translocase deficiency, HHH syndrome. Most patients have intermittent hyperammonemia accompanied by vomiting, lethargy, and coma in extreme cases. Growth failure and intellectual disabilities. Seizures will be there. Spasticity will be very common for these children. So common stressors affecting the urea cycle. So urea cycle function may stress common stressors. You have to remember these things when you are going to give consultation to the parents of the child. Genetic defect is an enzyme. For most of these things, we can do nothing. Damage to the liver, both chronic and acute. And chemical toxins, ETOH and industrial toxins. And we have covered this in your biogenic transformations, detoxifications. So these are the chemical toxins with which we have to play miserably to end up in urea cycle disorders. Other metabolic diseases also may add to this. Organic acidemias, methylmalonic aciduria, propionic aciduria, all these things will be ending up in organic acidemias. Pyruvate carboxylase deficiency. Most of you have written this very nicely. So I am very glad in your answer scripts while I am going through in the Viva. That's pyruvate carboxylase deficiency. All of you have written nicely, but most of you failed to write down the names, ketogenic amino acids, transition amino acids. So PKUD అన్నది రాయడానికి ఏమి అంత కష్టం ఉంది. ఒక సెకండ్ శ్రమ పడితే క్లారిటీ బాగా వచ్చింది కదా, అది రాశారు కాకుండా. అయినా సరే we have considered that as an answer and we have given you the full mark. So pyruvate carboxylase deficiency and fatty acid oxidation defects also will contribute to this. Galactosemia will also contribute. Tyrosinemia will contribute to this. Glycogen storage diseases and infectious or viral processes also will contribute at the last. So viral processes, infectious processes will contribute to this. So you have to go through this very carefully once again. Genetic defect in an enzyme, damage to the liver, both chronic and acutely, chemical toxins, ETOH and industrial toxins, other metabolic diseases, organic acidemias like methylmalonic acidemia, propionic acidemia, pyruvate carboxylase deficiency, fatty acid oxidation defects, galactosemia, hyperuricemia, and glycogen storage diseases. Infectious or viral processes also contribute. That should be given as another slide. So please note down. I'll be waiting for your taking it down into your notebooks. So common stressors affecting urea cycle function, drug effects on cycle. So direct interference with enzymes. So the drugs which will damage the urea cycle and cause these problems, how they act is they directly interfere with the enzymes. So enzymes లేకపోతే ఇంకా further procession జరగదు కదా. So the drugs will affect on the cycle by direct interference with enzymes. Valproic acid. Valproic acid is given to prevent conversions in the child. అందుకే చిన్నపిల్లలకి వాల్ప్రాయిక్ యాసిడ్ ఇవ్వడానికి కొంచెం భయపడతాం. ప్రీవియస్ హిస్టరీ అంతా జాగ్రత్తగా we have to go through, and if such problems are there in the families, we should better stop giving valproic acid. కానీ ఈ రోజుల్లో ఎవరో అంతగా గట్టిగా అవన్నీ they are not going into the details of the family history. Straight away they are giving valproic acid, but when it is coming to me, I am not going it directly unless otherwise I go for this. Safe history. So Depakot is the name of the drug, valproic acid. Chemotherapy, particularly when we use cyclophosphamide for the cancer, when we use cyclophosphamide as a chemotherapy, then the drug cyclophosphamide will affect the cycle by direct interference with the enzymes. So damage or general disruption of hepatic function. For many reasons, hepatic function may be damaged, and that will generally disrupt the hepatic function. And the systemic antifungals, this is most important one for your future. Most of us will be having tinea cruris, tinea capitis, tinea మొత్తం బాడీ అంతా టీనియాసిస్ వచ్చేస్తుంది. టీనియా క్రూరిస్ లేని వాళ్ళు అసలు చాలా తక్కువ మంది ఉంటారు. పెద్దవాళ్ళలో వెట్ అట్మాస్ఫియర్, కొంతమందికి డయాబెటీస్ అది ఉన్న వాళ్ళలో 45-50 ఏళ్ళ వయసులో టీనియా క్రూరిస్ గజ్జల్లో పూర్తిగా రాయల్ రీజియన్లో బ్లాక్ అయిపోయి దురద. As long as they are moving with the people, they will fear for getting observed. అందుకోసం గోక్కోకుండా అలా ఉంటారు పాపం. బట్ ఇంటికి వెళ్ళి బట్టలు తీసిన తర్వాత గోక్కోవడం ఒకటే పని, గీక్కుంటూ ఉంటారు అంతే. బాత్రూంలో పోయి తలుపు వేసుకొని గంటల కొద్దీ అక్కడే గీక్కుంటూ ఉంటారు. అన్నెసెసరీ దే విల్ బి ఇంజరింగ్ ద స్కిన్, అండ్ ఫర్దర్ ట్రామా విల్ కాజ్ ఫర్దర్ బ్లాకెనింగ్ and further spread of the fungal infections. So you remember this, when such a case comes to us, the systemic antifungals, hydroconazole istuntam sir. So hydroconazole iche mundu we have to find out whether they are having urea cycle disorders. Urea cycle disorders gaani, kidney problems gaani, or heart problems gaani unnayi ante we should better stop giving hydroconazole. అందుకే హైడ్రోకానజోల్ ఏదైనా స్కిన్ స్పెషలిస్ట్ ఇవ్వాలి అనుకుంటే 1000 క్వశ్చన్స్ అడుగుతారు. ఏమిట్రా ఇంత చాదస్తంగా అడుగుతారు? క్లియర్గా కళ్ళకి కనపడుతుంటూ ఇంత నల్లగా గజల్లో గ్రాయిన్స్లో ఇలా అయిపోయి ఇంత దురద వస్తుంది నాయనో అని చెప్తున్నా సరే వీళ్ళు నమ్మరేమిటి, ఇంకా బయోప్సీ అంటారు, ఇంకా దాన్ని తీసి ఫంగల్ కల్చర్ అంటారు, ఇవన్నీ ఏమిట్రా బాబు అని విసుక్కుంటూ ఉంటాం. కానీ ఎవ్రీబడి ఈస్ కరెక్ట్ అట్ దేర్ ఓన్ స్పెషాలిటీ. ఆల్ సెడ్ అండ్ డన్, of course they are all great specialists. 3 ఏళ్ళు కష్టపడి చదువుకున్నారు. సో వాళ్ళని అదొకలాగా మనం కన్సిడర్ చేయకూడదు. సో డ్యామేజ్ టు జనరల్ డిస్రప్షన్ ఆఫ్ హెపాటిక్ ఫంక్షన్, and whenever systemic antifungals are going to be incorporated for any disease, we have to be very careful about this urea cycle disorders. Otherwise we will lose the patient and chemotherapy from hepatotoxic effects. So the chemotherapy may induce hepatotoxic effects and acetaminophen. అందరికీ ఏదో acetaminophen తలనొప్పి వచ్చినా జ్వరం వచ్చినా ఓ అని ఇచ్చేస్తూ ఉంటాం. No, it's not so safe. Acetaminophen is not safe. Similarly, corticosteroids. So when we are putting the patients on corticosteroids, it will induce catabolic effect, and most hyperammonemia will be contributed to that. So corticosteroids is given as a last one because most of the cases we are having a tendency to give corticosteroids, especially for this COVID patients. But we should be very careful. We have to gauge the progress of the patient when we are keeping him on corticosteroids because of its catabolic effect. So common stressors affecting urea cycle function. Vascular bypass of liver. ఆ bypass చేసిన దగ్గర vascular bypass కి scarring వచ్చేస్తుంది అనమాట. ఏదైనా bypass చేసినప్పుడు scarring జరగడం most common. When completely it is getting healed, healing is always by scarring, isn't it? So vascular bypass of liver is by scarring or vascular bypass. Bypass పెట్టడం వల్ల కూడా scarring జరగవచ్చు. So bypass చేస్తున్న ప్రొసీజర్ వల్ల కూడా scarring జరగవచ్చు. So nitrogen overload of the system will take place, massive hemolysis, such as large bone fracture or trauma, total parenteral nutrition, TPN. TPN గురించి న్యూట్రిషన్ లో చెప్పాం. Total parenteral nutrition అని కూడా stress effect వస్తుంది. Protein catabolism from starvation or bariatric surgery. Bariatric surgery చేయించుకొని బరువు తగ్గడం కోసం హ్యూజ్ బాడీ బాగా వచ్చేసిన వాళ్ళు బేరియాట్రిక్ సర్జరీ చేయించుకున్నప్పుడు వాళ్ళు చచ్చిపోతే దానికి కారణం ప్రోటీన్ కెటబాలిజం ఫ్రమ్ స్టార్వేషన్ ఆర్ బేరియాట్రిక్ సర్జరీ. రిమెంబర్, చాలా మంది పెద్దవాళ్ళు చచ్చిపోయారు దీనివల్ల. పోస్ట్ పార్టమ్ స్ట్రెస్, డెలివరీ అయిన తర్వాత ఏమి ఫుడ్ పెట్టకుండా స్ట్రెస్లో ఇండ్యూస్ అయిపోవడం, అది తినకూడదు ఇది తినకూడదు అని చంపుకు తింటారు. సో పోస్ట్ పార్టమ్ స్ట్రెస్ will also lead to this stress. Heart lung transplant, this is most dangerous one. చేసేయడం ఏం పర్వాలేదండి అంటాం కానీ తర్వాత జాగ్రత్తగా మానిటర్ చేసుకోవడం ఇంపార్టెంట్. renal disease, GI bleeding, gastrointestinal bleeding. So remember, these are most important one you have to remember. Now diagnosis. The most important step in diagnosing urea cycle disorders is clinical suspicion of hyperammonemia. అందుకే దీన్ని రెడ్ లెటర్ అండర్లైనింగ్ కింద ఇచ్చాను అనమాట. సో ద మోస్ట్ ఇంపార్టెంట్ స్టెప్ ఇన్ డయాగ్నోసింగ్ యూరియా సైకిల్ డిసార్డర్స్ ఇస్ క్లినికల్ సస్పిషన్ ఆఫ్ హైపర్అమ్మోనిమియా. ఎంత నాలెడ్జ్ ఉంటే కానీ మీకు క్లినికల్ సస్పిషన్ రాదు. అందుకోసం ఇంత నాలెడ్జ్ మీకు ఇప్పుడు ఇవ్వడానికి ప్రయత్నం చేశాం. సో ప్లాస్మా అమ్మోనియా మోర్ దాన్ 150 millimoles per liter, అది 260 milligrams per deciliter or higher in the neonates, 100 millimoles per liter, 175 milligrams per deciliter, millimoles milligrams రెండు ఇచ్చాము, జాగ్రత్త చూసుకోండి, or higher in the older children and adults. Proper technique and handling should be required for this. Normal anion gap will be there. All of you have written very nicely about anion gap. So I think that all of you are fit to receive this knowledge. That's why I incorporated all these slides for you in this class. Normal blood glucose, pH and CO2 can vary with degrees of cerebral edema and hyper or hypoventilation. So qualitative plasma amino acid analysis, quantitative plasma amino acid analysis, that's very difficult, and I have done it in Bombay. So specific enzyme activity is most important, and that also is very difficult for us at this present strategy. And genetic testing, that's also is difficult. So diagnosis, of course, always you'll be knowing this when you become a pediatrician at a later stage after completing your MBBS, when you go into MD pediatrics, and afterwards when you become a super specialist with MD pediatrics, if you go for DM neonatology, you'll be knowing this chart. Until then, I think you may not be able to get more information about this. You'll be confused moreover. Anyhow, I wish as Out of my 21 students, 8 students are pediatricians, and only one student is super specialist in pediatrics. I'm so glad they are still communicating with me whenever they have a problematic case, and I tend to recollect all this information and tend to give a feedback to all of my students at this age of my life, at 68th year of my life. So my students are happy and I am happy with my students. So diagnosis for CPS1, OTC and NAGS, enzymatic diagnosis is made on liver biopsy. Enzymatic testing for ASS and ASL can be done on fibroblast samples. Arginase can be tested on red blood cells. ఏది దేని మీద టెస్టింగ్ గుర్తుపెట్టుకోవాలి, అందుకోసం ఇది ఇచ్చాను. For CPS1, OTC and NAGS, enzymatic diagnosis is made on a liver biopsy. Enzymatic testing for ASS and ASL can be done on fibroblast samples. Arginase can be tested on red blood cells. So this is most important one. Characteristics of urea cycle defects. Urea cycle defect, NAGS deficiency, enzyme deficiency is N-acetyl glutamate synthase. Amino acids, glutamate will be increased, arginine will be decreased, citrulline will be decreased. Orotic acid is normal. CPS deficiency, carbonyl phosphate synthase deficiency enzyme will be there. Glutamate will be increased, arginine will be decreased, citrulline will be decreased, orotic acid will be normal. OTC deficiency, ornithine transcarbamylase enzyme deficiency, glutamate will be increased, arginine will be decreased, citrulline will be decreased, and orotic acid will be highly increased. Citrullinemia, arginosuccinic synthase, glutamate will be increased, arginine will be decreased, citrulline will be increased many times, and orotic acid will be slightly increased. Arginosuccinate lyase residuria, that is glutamine will be increased, arginine will be decreased, citrulline will be increased slightly, and orotic acid also will be found. So argininemia, arginase will be enzyme deficiency, glutamine will be increased, arginine will be decreased, and orotic acid will be via media. So management, treatment of acute manifestations is most important, for which most of the times hemodialysis is the answer. So for the hemodialysis aims at bringing down the ammonia levels less than 150 micromoles per liter. For this, peritoneal dialysis is not effective. Hemodialysis only is effective, that will answer bringing down the ammonia levels promptly. So it's easy to start the peritoneal dialysis, but it's not effective for small children at that stage, neonatal stage. Pharmacological intervention to allow alternative pathway that will facilitate the excretion of nitrogen. This is most useful for most of my students. I advise this, and they are benefiting the patients by pharmacological interventions to allow alternate pathways for excretion of nitrogen. Nitrogen scavenger therapy is number 1. Sodium phenyl acetate and sodium benzoate. That is intravenous for acute management, oral for long-term maintenance. So for oral long-term maintenance, so sodium benzoate is being utilized by most of my students for MD pediatrics and DM neonatology. So deficient urea cycle intermediates need to be replaced, like arginine and citrulline. This is most easy. You can get a sachet of arginine. So deficient urea cycle intermediate need to be replaced. Arginine sachets we can buy in the market. Of course, 16 rupees and 25 rupees at one sachet. Of course, the life is saved at the cost of this medicine. Cost effective. This treatment is cost effective. The deficient urea cycle intermediates need to be replaced. The arginine can be given and citrulline can be given. For NAGS and CPS1 deficiency, carbamyl glutamate, carbaglu, that is the sachets available in the market. But carbaglu is not so rampantly available in India. And my students, like the super specialists in neonatology, they are now starting placing the indent in the market, and Now they are trying to get this kappa glue. Remember this. There is no time for learning. Time and diet waits for none. 2 lives are needed to learn all these things. So remember, whatever that's coming onto your PowerPoint projection, try to register it into your brains or onto your books. So management, treat the catabolic state with calories from glucose, fats and essential amino acids. Complete restriction of protein should not exceed 12 to 24 hours. Enteral nutrition is preferred. The placement of NGT, NJT at admission may be required. Other strategies like low dose continuous infusion of insulin with the maintenance of adequate glucose delivery is most important when we are giving insulin. Long-term treatment of manifestations, decrease the nitrogen load. The infants will require 1.2 to 2 grams of protein per kg body weight. Typically, half of the required protein is provided as essential amino acids and half as natural protein. This is most important. I have we all covered this in nutrition chapter, and while I am taking the lecture hours in amino acid metabolism. So we have to decrease the nitrogen load, and the infants, as you know, they require 1.2 to 2 grams of protein per kg body weight. Infants. So typically, half of the required protein is provided as essential amino acids and half as natural protein. So use nitrogen scavengers to provide alternative routes for the nitrogen disposal. Just now I have told you about nitrogen scavengers. Prompt replacement of citrulline or arginine. It should be prompt. మేనమేషాలు లెక్క పెడుతూ ఇవాళ చూద్దాం రేపు చూద్దాం అయ్యో ఇంత డబ్బులా ఏం చేద్దాం అలా ఆలోచించకూడదు. When you want the baby, you have to promptly replace the citrulline or arginine. Carbamide, glutamate, carbo glue replacement is most important. And liver transplantation, of course, it will be considered only after many discussions, especially at the high levels in All Institute of Medical Sciences, Delhi, and the Postgraduate Institute of Medical Sciences, Chandigarh, and Jawaharlal Nehru Institute of Postgraduate Medical Education and Research at Pondicherry. So only at such places only you can have the liver transplantation. And one of my classmates underwent liver transplantation in the United States of America. He was my classmate's elder brother. My classmate is an engineer and he is also an engineer. They are living in the United States of America. So they got this by the kind generosity of the United States of American people. So they opted for liver transplantation at that stage. So minimize the risk of respiratory and gastrointestinal illness through home care. When you take the patient into hospitalization, lots of cross-bed contaminations will be available. That's why respiratory and gastrointestinal illnesses will be fulminant in hospital management. That's why we have to prefer to manage the case in the home. So home care is most preferred one than hospitalization. Immunize all the usual schedules. Pneumococcal vaccination and the influenza vaccination, all these things are most essential and emergency. 1 month gap loni rendu change cheyali. Of course, very costly. So immunization for influenza costs 1,400 rupees for one injection. And pneumococcal vaccination will cost around 2,000 rupees for one schedule. And we have to give it 2-3 times. So remember, these are cost effective. Immunize on usual schedule. Provide multivitamin and fluoride supplementation also. అందుకే మీరు రాసిన ఎగ్జామినేషన్ పేపర్లు నేను చూశాను, చాలా మంది ఫ్లోరైడ్ సప్లిమెంటేషన్ గురించి చక్కగా రాశారు. ఐఎమ్ వెరీ హ్యాపీ. బట్ అట్ ద సేమ్ టైం మోస్ట్ ఆఫ్ యూ ఫెయిల్ టు రిప్రజెంట్. ఫ్లోరైడ్ ఎక్కువైపోతే ఏమవుద్ది, జీనో వాల్కమ్ డెఫిషియన్సీ, డిఫార్మిటీ, స్కెలిటల్ ఫ్లోరైడ్ ప్రాబ్లం గురించి చాలా తక్కువ మంది రాశారు. ఐఎమ్ హ్యాపీ టు గివ్ ఫుల్ మార్క్స్. So whenever I found this genovalgum deformity mentioned by in your answer scripts. So use antipyretics appropriately. Ibuprofen is preferred over acetaminophen. ఈ acetaminophen ఇచ్చినాక చచ్చిపోయిన పేషెంట్స్ చిన్నపిల్లలు చాలా మంది ఉన్నారు. One of my senior colleagues from my village was there. He was a great man. He worked as superintendent of government eye hospital. He is the first superintendent. He is a great man. He got a small granddaughter, and that granddaughter was given acetaminophen for febrile incidents. జ్వరం వచ్చిందని acetaminophen ఇస్తే he lost that child. మనోరాల పేరుతోటి ఆ క్లినిక్ కూడా రన్ చేస్తున్నారు. ఆయన చాలా పెద్ద వయసు అయిపోయింది పాపం. ఆల్మోస్ట్ స్టాప్ డూయింగ్ ఎనీ ప్రాక్టీస్ ఎక్సెప్ట్ ఫర్ ద పీపుల్ లైక్ మీ ఈజ్ నాట్ గివింగ్ ఇంటర్వ్యూ. సో యూస్ ఆఫ్ యాంటీబయాటిక్స్ should be done appropriately. That's why I am trying to give this type of examples. Ibuprofen is preferred over acetaminophen. I think I am giving you time. There is still half an hour time is there. That's why you can slowly take down the things. Explanations. Diagrams you can get in any book, but explanation is most important. This is most important. Glutamate dehydrogenase is controlled allosterically. High energy inhibits it. Low energy levels activate this. These two things you have to remember for Viva. This hexameric and all these things, you need not try to stress on your brain. But GDH is controlled allosterically. High energy levels inhibit ATP and GTP. Low energy levels activate ADP and GDP. NADP plus can replace NAD plus. This is most important. Ammonium ion is toxic to humans. It's produced in the mitochondria and used to make carbonyl phosphate. Carbonyl phosphate means urea cycle, urea production start out. And because of mitochondria is the scavenger. Your maternal mitochondria saves the human race from getting extinct. అందుకోసం మదర్ని ఎన్నిసార్లు ఎన్ని విధాలుగా మనం అడార్న్ చేసినా తక్కువే. ఏమి చదువుకున్నా చదువుకోకపోయినా మన తల్లి మనకి మెటర్నల్ మైటోకాండ్రియా ఇచ్చి మనల్ని రక్షించి ప్రాణంతో నిలబెట్టి 100 ఏళ్ళు సక్సెస్ఫుల్గా నిలబడేలా చేసింది. అందుకోసం మాతృదేవో భవ అదే ముందు అన్నారు. పితృదేవో భవ అని మొదలెట్టేదా శ్లోకాన్ని? నో. మాతృదేవో భవ, పితృదేవో భవ, ఆచార్య దేవో భవ మేమందరం మిమ్మల్ని అందరినీ తిట్టి కొట్టి నానా బాధలు పెట్టి ఇన్ని పవర్ పాయింట్ ప్రదర్శనలు పెట్టినందుకు. అండ్ ఫైనల్గా అతిథి దేవో భవ, ఇంటికి వచ్చిన వాళ్ళకి వాళ్ళ మంచితనాన్ని చూరగొన్నట్టయితే వాళ్ళు దీవిస్తారు, వాళ్ళ దీవెనలే మనల్ని రక్షిస్తాయి అంటారు. సో మాతృదేవో భవ, మెటర్నల్ మెథడ్ అంటే రిమెంబర్. Carbonyl phosphate synthase is in the mitochondrial matrix. Salute this. Carbonyl phosphate synthase is in mitochondrial matrix. So ammonium ion is the source for ammonia. The hydrolysis of 2 ATP make this reaction essentially irreversible. Akkade rendu ATP poyina sare it's cost effective, doesn't matter. So N-acetyl glutamate is an allosteric activator. So N-acetyl glutamate is available as an nephrosev tablet in the market. Of course, it's costly, 17 rupees for one tablet. And most of the times, I manage my patients with one tablet per day over a prolonged period of 3 months. And then they will come down to normal. And if necessary, we'll continue it. So this is most important. So complete enzyme levels, arginosuccinate synthase, arginosuccinase, arginase, ornithine trans carbamylase, and fumarate is oxidase. This is the connection to citric acid cycle. This is most important. All of you should try to represent this. అంత రాసిన ఎగ్జామినేషన్లో ఈ మాత్రం 4 గీతలు గీసి 4 అక్షరాలు రాయడం కష్టం అనుకోకూడదు. చాలామంది అక్కడికి వచ్చేసినాక అయిపోయి స్పీడప్ చేసేసి రాసింది ఇంటెలిజిబుల్గా, అంటే చదవడానికి అవకాశం లేని కొక్కిరి గీతల్లా గీసేస్తున్నారు. అది తప్పు. కొంచెం జాగ్రత్తగా రాస్తే వాల్యూ చేసిన వాడు ఆనందపడి దిగుతాడు, అప్పుడు మంచి మార్కులు పడతాయి. సో కనెక్షన్ టు carboxylic acid cycle, fumarate is oxidized to oxaloacetate by carboxylic enzymes producing NADH. Oxaloacetate accepts an amino group instead of being condensed with acetyl-CoA. Glutamate dehydrogenase is the control site. So complete urea cycle అన్ని కల్పించామన్నమాట. So control of other sites by glucagon, cortisol, insulin. So insulin ఎలా అన్నదానికి ఆన్సర్ ఇక్కడ. So negative influence and positive influence. So positive influence glucagon and cortisol. Negative influence insulin and growth hormone. అదొక నుంచి అవి రెండే కదా, గుర్తుపెట్టుకోవడం అంత కష్టం కాదు. So glutamate dehydrogenase is the control site. ADP positive influence, GDP positive influence, ATP and GDP negative influence, and NADH also is negative influence. So summary of reactions and energetics. So this is most important. 4 high energy phosphate bonds equivalents are used for these reactions, and 2 NADH are produced. You have to write it repeatedly on paper, and you have to talk about this with your colleagues, and then only you can remember it. And once you discharge your knowledge to your colleague, then you will definitely remember it with a definite concern. So these are the NADH axes. Then hyperammonemia. So normal blood ammonia is 10 to 14 millimoles. Deficiencies of carbonyl phosphate synthase are any enzyme in the urea cycle causes high ammonia ions. It affects on central nervous system and can lead to irreversible brain damage. Treatment strategies depend on which enzyme is deficiency. So arginosuccinase deficiency, each one ఒక్కొక్కటి చూపిస్తున్నాం. So for this, arginine excess should be supplied. So block is at number 2. I think you are taking down, and you cannot get it back at any time in your life. This is once forever. This is the last lecture, and after third interval is over, we are still reviewing. So my time is over. Ketogenic and glucogenic amino acids, nitrogen for oral bacteria. Remember, urea is a major source of nitrogen for oral bacteria. It diffuses through most membranes and in saliva. Bacterial urease produces ammonia. So glutamate dehydrogenase incorporates ammonia into alpha-nucleic acids and obtain amino acids for bacterial growth. So Streptococcus salivarius urease activity affects oral microbial ecology. It produces ammonia, which in addition to promoting growth, neutralizes the acids produced by other bacteria in our oral cavity. Streptococcus salivarius urease gene was introduced into Streptococcus mutans GS5. It was expressed and during glucose metabolism reduces pH decrease and duration. So my time is over. The other people are waiting. Hope God should bless you with the divine knowledge and the knowledge of utmost clarity and effectivity. So effectively ఉండాలి knowledge. వచ్చిన నాలెడ్జ్ని అప్లై చేయలేకపోయి కేవలం అన్ని మగప్ చేయడం రాయడం అంతవరకే ఉంటే చాలా విసుగుగా ఉంటుంది అనమాట. సో దిస్ ఈస్ హౌ యూ హ్యావ్ టు అప్లై యువర్ నాలెడ్జ్. సిమ్టమ్స్, ఇది మోస్ట్ ఇంపార్టెంట్ క్లాసెస్. Each one was given. OTC is located on the X chromosome. This results in the majority of severe patients being male. So females also will be affected, but they will tend to present outside the neonatal period. చిన్న పిల్లలు ఆడపిల్లలు ఇంట్లో ఉన్న పిల్లలకు వస్తాయి అన్నమాట, స్టార్ట్ అవుతారు. ASSD, citrin deficiency, most important. So most of them are reported as Japanese or Asian sharing common mutation. So they avoid carbohydrates rather than proteins. I got only one patient for this in Muslim community in Visakhapatnam. I'm so happy to get this patient, and still so the disorder is marked by chronic hepatic enlargement, elevated SGOT, SGPT, AST, ALT ఎక్కువగా ఉంటాయి. Biopsy of the liver shows enlarged hepatocytes, and over time progresses to fibrosis. And etiology is not clear, and one of you should find it out to get Nobel Prize. So we can also develop trichorexis nodosa. తల మీద వెంట్రుకలన్నీ ముద్దలు కట్టేస్తాయి, జుట్టులు ముద్దలు కట్టేస్తాయి. దానికేమో ఏదో చిన్నప్పుడు ఏదో దేవుడికి మొక్కుబడి తీర్చలేదు కాబట్టి తలంతా వెంట్రుకలన్నీ ముద్దలు కట్టేసి అని అనుకుంటూ ఉంటారు. రిపీటెడ్గా బోడుగుండు చేసేస్తుంటారు ఆ పిల్లలు. A node-like appearance of fragile hair, which usually responds to arginine supplementation. Arginine supplementation ఇస్తే క్రమంగా తగ్గిపోతూ ఉంటుంది. So progressive spasticity, more in the lower limbs, seizures, gradual loss of intellectual attainments, failure to thrive. Other symptoms present early in the life include episodes of irritability, anorexia, and vomiting. HHH, hyperornithinemia, hyperammonemia, homocystinuria, inuria. Homocystinuria is thought to originate from transcarbamylation of lysine. So most patients have intermittent hyperammonemia accompanied by vomiting, lethargy, and coma, growth failure, and intellectual disabilities. Seizures and spasticity are most common. So common stressor affects in urea cycle are genetic defect in the enzyme, damage to the liver, chemical toxins, other metabolic diseases, organic acidemias, pyruvate carboxylase deficiency, fatty acid oxidation defects, galactosemia, tyrosinemia, glycogen storage diseases, infectious problems or viral processes. So drugs affects the cycle by direct interference with enzymes, and valproic acid to control the fits in children will be giving, that also will affect. Chemotherapy, particularly cyclophosphamide, damage to general disruption of hepatic function, systemic antifungals, chemotherapy from hepatotoxic effects, acetaminophen, most dangerous, corticosteroids, catabolic effect, vascular bypass of liver by scarring, or the vascular bypass itself will cause scarring, nitrogen overload of the system, massive hemolysis such as large bone fracture or trauma, total parenteral nutrition, TPN, protein catabolism from starvation or bariatric surgery. Bariatric surgery చేసుకున్నాక చచ్చిపోవడానికి కారణం ఇదే. So protein catabolism and starvation or bariatric surgery will lead to the common stressor affecting the urea cycle function. Postpartum stress is most common in India in rural areas. Heart lung transplant, renal disease, gastrointestinal bleeding. The most important step in diagnosing urea cycle disorder is clinical suspicion of hyperammonemia. Suspicion undala డాక్టర్ అన్నవాడికి. సస్పెన్షన్ లేకుండా అంతా బాగుంది అన్నీ బాగున్నాయి అనుకుంటే ఇలాంటివి బయట వెలుగులోకి రావు. సో ప్లాస్మా అమ్మోనియా, నార్మల్ anion graft, normal blood glucose, pH and COT can vary with the degree of cerebral edema, hyper or hypoventilation, quantitative plasma amino acid analysis, specific enzyme levels, genetic testing. For CPS1, OTC and NAGS, enzymatic diagnosis is made on liver biopsy. Enzymatic testing for ASL can be done on fibroblast samples. Arginase can be tested on red blood cells. So this is the characteristics of urea cycle defects. Management, hemodialysis, and peritoneal dialysis is not effective for small cerebral. Hemodialysis only to keep up the ammonia levels below 150 millimoles per liter. And pharmacological intervention, nitrogen scavengers, sodium phenylacetate and sodium benzoate IV for acute management or for long-term management. Deficient urea cycle intermediates need to be replaced by arginine and citrulline. For NAGS and CPS1 deficiency, carbamyl glutamate, carbaglu sachets. Catabolic state with calories from glucose, fats, and essential amino acids. Complete restriction of protein should not exceed 12 to 24 hours. Enteral nutrition is preferred. The placement of NGT, NJT at admission may be required. Other strategies, low dose continuous infusion of insulin with maintenance of adequate glucose delivery, and long-term treatment manifestations, decrease nitrogen load. Infants require 1.2 to 2 grams of protein per kg body weight. Typically, half of that required protein is provided as essential amino acids and half as natural protein. Use nitrogen scavengers to provide alternative routes for nitrogen disposal. Prompt replacement of citrulline or arginine is most mandatory. Carbamyl glutamate, carbaglu is most essential. Liver transplantation, if it is available, you can always go for that. Minimize the risk of respiratory and gastrointestinal illness through home care only. Immunize all the usual schedules. Provide multivitamin and fluoride supplementation. Use antibiotics appropriately. Use ibuprofen than acetaminophen. Thank you very much. God bless you to become very good doctors and very good citizens of India, useful for the entire community and throughout the world. That's which is